You're welcome to my channel. Today I'll be talking about contraindications to clot busters, meaning contraindications to thrombolytic agents. Have you been selected for thrombolysis, or you're a physician thinking about selection of candidates for thrombolytic agents, either because of pulmonary embolism, ischemic stroke, or ST-elevated myocardial infarction? Nothing is rigid. All we need to do is to discuss with the patient, the family, or the substitute decision maker. Why that? Consent must be written and signed. We have to contact the hematologist, neurologist, stroke specialist, pulmonologist, or cardiologist as the case might be. We must weigh the benefits versus the risk, particularly in pregnancy. The good candidates for thrombolytic agents are individuals with stroke and already proven through neurological examination to have neural deficits, or CT has confirmed the ischemic region of the brain, or coronary angiography when it comes to heart attack has confirmed where the thrombus is, or the stroke timing is presenting within 4.5 hours or less, or ST-elevated myocardial infarction is presenting within 30 to 90 minutes. It might be greater than 4.5 hours of stroke onset, or greater than 90 minutes of ST-elevated myocardial infarction onset, but the duration from the onset to the administration of thrombolytic agents, lower the efficacy. Anyone above 18 years, that is great, but if adolescent, must be cleared by a pediatric specialist. Absolute contraindications: active bleeding, postpartum hemorrhage, bleeding peptic ulcer disease, intracranial neoplasm, intracranial hemorrhage, infective endocarditis not treated. Still under absolute contraindications is subarachnoid hemorrhage, aortic dissection, recent major surgery in the last 3 to 4 months, current trauma with active bleeding, massive brain ischemia or massive brain infarction. Relative contraindication means you can still survey the situation, like hyperglycemia, you can bring the glucose level down. Hypoglycemia, anything less than 2.5 millimoles per liter, you can increase that. And pregnancy, you weigh the benefits with the risk. Trauma or major surgery in the last 2 to 4 weeks, discuss with the specialist. Entered large aneurysm, entered, like I said, but be careful. In my bust. 80 years and fragile, and of course high blood pressure, depending on the value of the blood pressure. You cannot give thrombolytic agents when the BP is not below 185 over 105 millimeters of mercury. But don't crash the blood pressure, please. Still on relative contraindications, we'll have to check through the clotting profile. An abnormal clotting profile will reveal increased APTT, increased PT or INR, increased TT, or decreased platelets. If past medical history is showing intracranial hemorrhage or stroke in the last 3 months, you have to consult an appropriate specialist. And lastly, you can choose from Alteplase, that is recombinant tissue plasminogen activator, Tenecteplase, that is TNK. Streptokinase is not always used, and I'll give details about that later on. Reteplase, that is Retavase. You can choose any of the number 1, number 2, and number 3, that is Alteplase, TNK, and Reteplase. But we don't use Streptokinase often. I'll give you the reasons later on. There will be more info on all these medications very soon. With that, I've come to the end of this short presentation. guiding us through who can use thrombolytic agents and who cannot. And of course, rating consent after we have gone through the probable side effects and the benefits of the appropriate thrombolytic agents we may use. Why is Tenecteplase more useful now compared to rtPA? We'll discuss that later on. So watch out for presentations on my channel so that you can get my presentations immediately they are published. I appreciate it.